Hi everybody, I'm Xavier. I'm from Florida State University. And I'll be talking to you about Gait, which I think was a great follow-up to the last presentation. So you can tell I'm about to go to APHA immediately following this because I included disclosure slides first. There's no conflicts of interest, but I will highlight that I am part of the Sustained Training in Aging and HIV Research Program, STAR, as well as our additional funders for this work. So following up on the last presentation, gait speed is a simple and widely used measure of physical function. So it's pretty simple. You assess it by following people along a certain distance, walking within a clinical setting. It's been linked to cognitive decline in older adults, and that's in general population. So we've seen that gait speed is predictive of cognitive decline overall, outside of HIV research. And slower gait speed has been linked longitudinally as well, which is part of the focus of this presentation, is thinking about this longitudinally. And so people have posited that this could be a useful clinical indicator for cognitive decline in clinical settings, including things like mild cognitive impairment, as well as things like dementia. It may be particularly relevant to people living with HIV, as we've seen in earlier presentations. There's accelerated aging among people living with HIV. We also know, and I know we'll talk about this more throughout the conference, that there are higher rates of neurocognitive impairment among people living with HIV. And there is some indication that there's slowed gait compared to general population among people living with HIV. However, there are limitations to the literature among people living with HIV, which include that most of the studies have been cross-sectional. There have been use of mostly global cognition tools like MoCA instead of looking at subdomains. And then most previous studies also haven't compared people living with HIV versus people without HIV directly. So they've seen higher slower gaits, but they haven't necessarily compared directly within the same sample. However, we do have a poster by Dr. Jones in the back later in the conference, so please check it out. That's comparing between those two groups, and we observed that there was slower gait when you're comparing within the same sample. But there's a possible bidirectional relationship between these two factors. So thinking about gait and cognitive function, we often think about gait speed as potentially an early indicator, but it's also possible that reduced cognitive function could also lead to impaired gait. So that presents us with this sort of double association issue, which cross-leg path models are great for examining. And so these are exploratory approaches using path models to examine both of these relationships simultaneously. So I'll show you a diagram for those of you who are not familiar, since it's very difficult to describe verbally. So we've got an example here with a fully elaborated model between gait speed and global cognition, where you can see we have 3 time points. There's time point 1 for both of these constructs, time point 2, and time point 3. And so we're looking at those middle associations. So here you can see these red indicators are the association between global cognition at the previous time point with gait at the following time point. And you can also think about it the other way. So gait speed at the previous time point followed by cognition at the second time point. And because we're modeling this as a cross-legged function, you can actually observe both at the same time. Instead of having to stage the model such that you're assuming that gait speed is predicting global cognition or vice versa. So we wanted to further examine this by modeling a cross-leg model. And we're also including subdomains of cognitive impairment or cognitive function in order to explore if there's particular domains that might be relevant. This is coming from the HNRP. There was a total of 285 people with HIV. Only 127 had 3 consecutive time points. There were more time points available, but this is what we did for our preliminary analysis. All the data comes from 2013 through 2024. We used gait speed using the short physical performance battery with a pace of an 8-foot walk. And then there was a comprehensive neurocognitive battery, which we have converted to demographically corrected T-scores, including global performance as well as the following, and global performance is the average of the domains. We used univariate and bivariate tests initially, and then we fit cross-legged models for global function as well as each of the domains. I'll present to you the ones that had significant pathways, but those that I do not present did not have significant pathways. I also observed the moderation effects and did not actually find any moderation by age. And so you'll see with the sample characteristics that this is not just people above the age of 50. So I did probe to see if the significant pathways were moderated and did not observe moderations as of yet. And then the final models are adjusted for covariates. So again, the sample is about 127 individuals living with HIV. The mean duration between time 1 and time 2 was nearly 2 years, and the mean duration between time 2 and time 3 was 1.4 on average. The mean age was around 50. Education was 14 years, mostly male, and the largest racial group was white, non-Hispanic. So looking at these results, we do see a signal for a prospective relationship between gait speed and global cognition, in which a slower gait speed does predict reduction in global cognition at time 2 from time 1. We see the same pattern with a few of the subdomains, so I'll walk you through those. We observed that for executive function from time 1 to time 2. The effect size was a little bit larger for this one. And then for motor skills, we also observed the same pattern. So we're seeing a signal for prospective relationship. We saw the same with learning, but interestingly at time 2 to time 3. But when we get into the last two domains, we see a little bit of a complication in which we also observed significant pathways from working memory to gait speed from time point 2 to time point 3, in addition to the gait speed to working memory association. And then for processing speed, we see that same small association from processing speed at time 2 to gait at time 3. And for simplification, I didn't include all the estimates for all of the relationships here, so I didn't want to complicate the slides too much. So we have observed in this analysis some evidence of prospective relationship between gait speed and global cognition among people with HIV, including across several of the subdomains, many of which sort of align nicely with the broader literature for older adults more broadly. And then we did observe some small associations coming from cognition to gait speed in some instances. So there is some potential evidence of a bidirectional relationship as well with those subdomains. But there's still more work that needs to be done, both observationally as well as in terms of clinical practice. So thinking through some of the cutoffs that could exist that would be relevant in clinical setting, or thinking about the time frame between or common causes, like discussing earlier, talking about inflammation or other early indicators that may be associated. Sort of some of that alludes to some of the limitations in the study, which included sort of attrition and sample characteristics, which may have influenced our ability to detect really small effect sizes. There were also some considerations like the time between time points and the number of time points. I think in a future study, I'd prefer to have the ability to look at different lengths of time between and have multiple time points with a robust sample if we want to really probe this association, as well as thinking through maybe cut points. We were looking at raw scores here, so we weren't thinking necessarily about indicators, clinically significant cut points. So thank you to all my collaborators, the STAR program, the participants, as well as the advisory board.